I request the attention of all the faculties and delegates. I will take few minutes of yours and let me introduce me and the faculty members of the session. So, a very good evening and welcome to one and all. This is Ankita from Clarnet, the science session assistant for a seamless experience. And Clarnet is India's most trusted and widely used digitech platform with multiple enriching services exclusively for doctors. Planet is very proud to be digital partner for this webinar organized by the National Neonatology Forum, Gujarat. And topic of today's session is lessons from the expert lung ultrasound. So without any further delay, sir, I would like to hand over the session to Dr. Kunal, sir. Please proceed with your talk. Over to you, sir.
Thank you so much, Ankita. So today is a privilege and a proud moment for me that my mentor, Dr. Pradeep Suryavanshi sir, is going to take a talk on lung ultrasound. So I'm very happy and eager to hear his talk. So first, I would request Dr. Shwetal ma'am to say a few words and then hand over to Vishal for the introduction.
Good evening, dear all, and most warm welcome to Pradeep sir for sparing from your busy schedule, sparing some time for Gujarat NNF. It's a privilege to have you on this platform. Thank you so much, sir. Indeed, the students will have a good academic phase today. Thank you, sir.
Vishal.
Yeah. So thank you so much, Kunal. And it's honor to introduce the Suryavanshi sir. And I think everyone know that Suryavanshi sir's achievement, and he's a teachers of the teachers, I would like to say. And he's one of the pioneer, in the neonatal hemodynamics, not only in the India, but at pan-Asiatic level. And he's one of the teachers who started the online teaching, as I remember, in the peak corona pandemic, and he almost trained more than 500 delegates, which include the not only the student but professor and consultant from all over the world. And if I talk about his achievement, I think it will take I think 10 to 15 minutes to describe his achievement. But if I summarize, he has multiple publication, more than 75. He is the author of the multiple books, including Hail Ultrasound, Eco, Atlas, and multiple books. And he's also pioneer of the lots of new thing in India. And if I talk about the consultant, lots of consultants in the not only in the Gujarat but all over the India train under his roof. Our Kunal Ayya, secretary, also trained under his mentorship, and I think he owned the more than 34 NICU mentorship in India. So I welcome Professor Suryavanshi sir, and over to you, sir. Thank you so much.
Okay, thank you, Dr. Shwetal, Kunal, and Vishal for the kind invitation and introduction. Just let me share my screen, and then I will. Okay, can somebody let me know whether am I audible and visible, please?
Yes, sir, you are clearly audible.
Perfect, perfect. So thank you, friends. Good evening, all team members who have joined. I think almost everyone I know, as by names and by your states and by your country. Today, in the next 45 to 50 minutes, we will try to discuss about very, very basics about point of care neonatal lung ultrasound. I know it is not feasible to cover me all, but I will try to put very important topics, very important thought process in your mind, so that you could able to gather the day-to-day practice, day-to-day importance of point of care lung ultrasound. What we will try to cover about various basics, indications of focus of lung ultrasound. We will discuss about the important signs of the lung ultrasound, and then the conditions which are useful for us in day-to-day practice. That way we'll go ahead. Friends, we are talking since the last 15 years about focus. But focus is a supplementary to your clinical examination and history. Always think one aspect, which is very important aspect, that history clinical examination comes first. Inspection, palpation, percussion, auscultation, it's always going to remain. The insonation, which we talk, is the fifth pillar. So one word you should understand now is the additional word we called as insonation, and that is very important aspect for all of us. So please utilize this word in your day-to-day practice. and utilize this importance of insonation. Now, what is the point of care ultrasound? The point of care ultrasound means you have a question in your mind. That question we want to solve on the bedside by checking the functions of by ultrasound, understand the physiology, and define the decision on the basis of finding from that point of care ultrasound. Next day or after 6 to 12 hours, you check the response of that point of care ultrasound. So this is a continuous sequence like your stethoscope. It is not one thing you are done the ultrasound and it is finished. You have to monitor the response, you have to see the therapy response, and then see how the baby has responded. It is called as a clinician perform ultrasound, point of care ultrasound, bedside ultrasound, or targeted echocardiography. These are the words we have used in the world. What is the role of point of care ultrasound in neonatology? Friend, definitely it is useful for diagnosis, critical assessment. I will show in lung ultrasound how it is useful. It is useful for screening, monitoring, prognosis. It is for procedure and therapeutic. And my main role is research. So this is what I would request all of you, that please concentrate research. Those members who have joined today think that you can produce one research in day-to-day practice. You can produce one point of care ultrasound research from India, so that in the world we take forward this opportunity. So this is what I would like today's session, that please think about lung ultrasound as a research, which is my aim important. What are the various components of point of care ultrasound in day-to-day practice? We all know about the brain and the echo. It's been going for last 20 years. The lung is there now for last 10 years. Gut has came well in the last 5 years. I would like to say that procedures and lines is very, very important. And just I mentioned research. Today we'll concentrate on the lung ultrasound. So what you need to know that in a day-to-day practice, along with my history clinical examination, this lung ultrasound is going to help me as my decision-making things. Now, what are the various points about the lung ultrasound and various indications for these ones? Now, what is the basic things about ultrasound? You should understand what is the basic ultrasound. The ultrasound probe will send the beams which will penetrate the tissue or the fluid through that ultrasound probe. Again, there is a reflection back from that transducer to the computer screen, and we see some picture. That picture is in the form of a black, gray, white, and then we interpret that picture. So ultrasound is nothing but penetration of the rays to the tissues, coming back to the monitor screen, creating the picture, and you interpret the picture. That is the basics of ultrasound. But the lung ultrasound is different. The lung ultrasound is actually the interpretation of artifact. Remember one word. Lung ultrasound is nothing but the artifact. We have ultrasound beams. Unfortunately, they cannot penetrate. They reach up to only pleural line. And the pleural line produce the artifacts. And these pattern of artifacts we see on the screen, that is called as lung ultrasound lines or interpretation of lung ultrasound. So what is the first message I want to give here? Lung ultrasound is nothing but the artifacts produced by the pleural line. Pattern of the artifacts produced by the pleural line, which is reflected on the screen, and we interpret that one. That's the first message you all should understand. It's a relatively new thing. Different definitions, different authors, different parameters. But the good part of the lung ultrasound is that you can use the lung ultrasound like X-ray in most of the neonatal respiratory conditions. So any respiratory distress, any respiratory support, you can think about lung ultrasound. That means I'm going to think about diagnosing the lung ultrasound for purpose of RDS, TTM, differentiating RDS from pneumonia, diagnosing pneumothorax effusion, edema, and BPD. These are the day-to-day practices of lung ultrasound. I can guide my surfactant therapy on the basis of lung ultrasound. I can think about repeat dose of surfactant on the basis of lung ultrasound. I can wean the respiratory support and extubate the baby on the basis of lung ultrasound. I can decide the diuretics in BPD about the lung ultrasound. So one side I'm talking diagnostic, one side I'm talking therapeutic. But friends, what I want a research from you all. You all are concerned. Kunal, can you mute the members? Kunal or somebody, can you just mute the members? So my expectation from all of you is the research. Yes, diagnosis is important, therapeutic is important. Therapeutic, basically the pleural effusion, tapping, or diagnostic therapeutic taps, that's happy. But once we think about research, that's the future for all of us in India. Ultimately, we need Indian research. Ultimately, we want to now think about producing our own research that will be good for all of us. Now, what are the ways of performing ultrasound? This is the most simplest ultrasound on the earth because you don't require a lot of changes, a lot of sweeps, a lot of tilts, a lot of rotation you don't require at all. The simplest method on the lung ultrasound that you can use simple, the linear probes, that's the easy option. The linear probe, 10 to 14 hertz, or if you have hockey stick, 14 to 18 hertz, that's acceptable for lung ultrasound. And only one thing you need to learn, please put the probe perpendicular. Please put the probe perpendicular into the anterior chest or lateral axillary line or posteriorly. That is what we require. That's it. If you tilt the probe, you don't get a good views. So perfect perpendicular is the need of lung ultrasound. If you are a little bit tilting, you will confuse with your lung ultrasound finding. So please, clinical findings. And once you put a probe perpendicular at right anterior, left anterior, we have right anterior upper, right anterior lower, left anterior upper, left anterior lower, axillary upper, lower, axillary upper, lower, and then posteriorly upper, lower, posterior upper, lower. These are the regions we need to scan. You just concentrate only perpendicular at present moment. Don't think about longitudinal at present moment. Only one view you think for learning basis as a first primary thing. That is what is useful for you. I told you that the Western people, they concentrate on RDS and they scan 6-region approach. While in Asia and Africa, we always tell the people, please concentrate on the posterior part because the pneumonia is the common diagnosis, which is not diagnosed in 6 region, which is diagnosed in 12 region. So second message I want to give to all of you, please think about doing posterior scan in India or Asia or Africa, where the pneumonia is the more diagnosis and pneumonia is picked up by posterior scan, not by anterior scan or lateral scan. You are going to miss anterior and lateral scan. If you are going to do anterior and lateral, you are going to miss pneumonia. But if you do the posterior scan, you will not miss the pneumonia. That's my second request, second message to all of you. For lung ultrasound, always do posterior along with anterior and lateral. That's the second thing you should understand. You can prepare a chart and you can design your reporting. Now let's go to the sum of the lines. We have heard so many times about these lines. Let's think about what are these lines. Now we talk about pleural line, A line, B line. You have to understand very simple stuff. Don't make things complicated. The simple thing measurement means the pleural line. To understand that, see the anatomy. We have skin, basically the subcutaneous tissue and muscles, then the ribs, intercostal muscles. The line that is a pleural line, visceral line, and the lung. That much we see. So this is the basic anatomy, what we see. I told you that the beam of the lung ultrasound will reach here. After that, it will not reach. So you are going to see the lung ultrasound picture up to this point and you can correlate. Now see this one, skin subcutaneous tissue. These are the ribs. These are the ribs. In between ribs, we have these intercostal muscles. And this is the one echogenic line. What we see is the first line, which we are going to define is a pleural line. So what is a pleural line? Pleural line is nothing but a thin, smooth, regular, hyperechoic, less than 0.5 millimeter thickness below the ribs. These are the ribs. Below the ribs, that line. This indicates the parietal pleura, and this is between the parietal pleura and the air, and this line is sliding. This line is sliding on the lung. This is called a lung sliding. So remember that this is a physiological, or this is the lung interface between the pleura and these ones. So that's the first line you have to identify in your day-to-day practice, is the pleural line. The second line you should understand is called as A line. Now I told you that lung ultrasound means artifacts produced by this pleural line. So this is the pleural line, first identify. And below, sorry, this is the pleural line. These are the ribs. These pleural line, and these are the ones which are artifact now. What are these artifacts? These lines, these horizontal lines, parallel, equidistance, like a bamboo-like picture. This is the bamboo-like equidistance picture. Parallel solid lines. These are nothing but A lines. So this the pleural line, and below these are the parallel lines, equidistance, bamboo-like lines, horizontal, echogenic. They are the A lines. A lines means air. 99.9% it is a physiological air. 0.01% is a pathological air, that is the pneumothorax. So third thing what we learned, A lines is a physiological, rarely it is a pathological. When you see the A line with the lung sliding, it is a physiological. When you see A line without lung sliding, it is a pathological. That's the third message you should remember. Very simple. A line with a lung sliding, physiological, that is a physiolocal air. A line without lung sliding, pathological, that's a pneumothorax. We'll come back to that point. Now the next point, friends, you need to understand is called as a B line. B line is nothing but they are arising from this pleura. These are vertical. They are vertical, laser-like, hyperechoic. You have seen the lasers. These are vertical, laser-like, hyperechoic. They indicates the liquid. A is air, B is liquid. So that is a liquid-liquid interface. In the first 48 hours of life, in every baby, you will see the B lines. After 48 hours, you will not see the B lines in normal babies. If the B lines is there, you can think that there is a lung edema. Various types of lung edemas are there. So what is the second message I want to give? B means fluid. In the first 48 hours, it is always physiological. Or it could be very high incidence, then we have to find out that. That's a different part. But after that, we need to define and design that B lines. That's a part of associated fluid in the body. So that's about the B lines. Now, various parts of the B lines, let's categorize these various parts of the B lines on the basis of simple B lines, or we are talking about the further patterns. Now, what is simple B lines? Simple B lines, now we can see that less than, these are the 1, 2, 3. You can see these 1, 2, 3, intercostal space. So we can see that these 1, 2, 3, in between you can see the anechoic area. These are laser-like 1, 2, 3. In the intercostal space, in between they are separated. These are very minute amount of fluid. This is a small fluid. B lines means the rain, small rain is falling. This small rain is falling. That's a simple B lines. That means minimal quantity of the fluid is there in the lungs. If I go further, in this picture, you can see the A lines also in between. So A lines are there, plus B lines are there. These are simple B lines. If my A lines are gone, now see A lines are gone, and these B lines have become confluent. So basically these rib shadows are still there. These rib shadows, these are the black rib shadows are still there. These are called as confluent B lines. That means more fluid in the lung now. From simple B lines, we talked about confluent B lines. From confluent B lines, if there are more than 3, 1, 2, 3, 4, confluent B lines in one lung area, it is called as a alveolar interstitial fluid. Initially the fluid was in the interstitium. Now it has become into the alveoli also. Hence it is called as AIS pattern. Fluid is increasing from simple B lines to the confluent to the AIS. That's what we talked. Now you can see the confluent to AIS pattern. From AIS, you can talk about the compact B lines. All these rib shadows are gone. There was a rib shadow in confluent. There was more than 3 confluent. And now whole AIS become as a one compact. There is no rib shadows. That's called as compact B lines. More fluid, more lung fluid. That's what we talk. So when the whole area of the lung looks white, it is called whiteout lung. So friends, now we can see this one. This is whole whiteout in each region of the lung. Anterior, lateral, posterior, all regions of the lung is whiteout. So from simple B lines, where you can see the B lines with A lines, in rib shadows also present. That's a simple B lines. A lines are gone, rib shadows are still there, confluent B lines. A lines are gone, and more than 3 confluent B lines, AIS pattern. Rib shadows are gone, A lines are gone. All AIS as compact, it's called as compact B lines. All the regions are compact, it's called as white lung. So go step by step. That's increasing the fluid. What we're talking about that, these are the increment in the fluid. So you can see these now. This is what we talk about, the confluent, AIS, and the white lung. This is what, there is a shadow. These are the more than 3. There is no rib shadows, there is no A lines. Multiple A lines, multiple A regions. Those people, they want to go through. This is a simple article written by our team. Please go through. This is article free available, which you can Google and just see that lung ultrasound in neonates, an emerging tool for monitoring critical infants. Simple, very easy. One of our DM candidate has written this article, and they have wonderfully mentioned that if you have simple B lines plus rib shadow plus A line, that's a simple B lines. Fused B lines, rib shadow seen, A lines absent, confluent. A lines, all fields are involved, rib shadows are gone, could be compact or whiteout lung. Very simple step-by-step approach, what we need to know. So the next key message, what we learned so far, A lines, artifact, horizontal artifact. That's horizontal artifact. That's arundel pleura. That's normal, physiological. A lines with lung sliding, physiological. A lines without lung sliding, pathological, pneumothorax. B lines, vertical artifact. These are the simple B lines, interstitial fluid. When they become compact, it's alveolar fluid. So these AIS pattern, what we call as alveolar interstitial syndrome or whiteout lung, that's what from interstitium to alveoli. I will discuss later on about the dynamic air bronchogram and static air bronchogram in the few points, but that's the basic things what you should understand. What are the other factors you should know also? So we learned pleural line, A line, B line. Now you should know the lung sliding. I just already mentioned the lung is sliding on the pleura. That's a lung sliding picture. This is the simple pictures. I'm going to show you videos to you. This is simple lung sliding, what you should understand. There is one more concept called as a lung consolidation. Lung consolidation means, Dr. Shweta Goel, don't write on the screen. Somebody please remove that lines. It is distracting me. Those who are controlling the panel, please remove those blue lines. That will be good for me. Consolidation means the lung is looking like liver, which is called as hepatization. And these are the features of RDS, pneumonia, and atelectasis. Kunal or Ankita, please remove those blue lines. I'll be happy to work on that. Lines will be better. Yeah. So what we are trying to say that consolidation means you have shed sign, and there is nice hepatization of the lung. This is the nice hepatization of the lung. This is what we talk about the pneumonias in that one. One more pattern, what we are talking. Just a minute. I will have to myself remove because I'm not comfortable.
I think, sir, you have to remove. Thank you, sir.
I have done that. I get
Please,
disturbed.
participant, don't do.
Yeah.
Thank you, sir.
Yeah, I usually get disturbed myself with these lines. I know we are learning lines, but don't put the lines on my screen. You learn the lines on the ultrasound. You learn the lines on the baby. That is pleural line, A line, B line. Thanks, friends. We have two terminologies. People often get confused with these two terminologies, double lung point and lung point. Double lung point is nothing but point between fluid and air in a normal lung sliding baby. So the lung sliding is present, and the point between A lines and B lines is called as double lung point. That's a feature of TTN. And the simple lung point, simple means only lung point between A lines and B lines without lung sliding. Now lung is not moving. Just observe, this lung is not moving. This is called as a lung point. So friends, what we are talking in the form of features. So I told you pleural line, I told you A line, I told you B line, I told you now consolidation, lung point, double lung point. These are important points. These are additional beach M mode patterns. It's called a sandy beach patterns and barcode sign. So basically you can see now the normal lungs, when you consider the normal lungs look like a sand and beach, while pneumothorax lungs look as a barcode sign. I'll come back to that again. So these are the few features you need to know as artifacts in the lung ultrasound. Now let's go to the next 15 minutes about the disease conditions which are useful to all of us. In the disease conditions, okay, to revise the previous part, A lines are horizontal artifact, which could be physiological, pathological. A lines with a lung sliding is a physiological air. A lines without no lung sliding is a pathological, that is pneumothorax. That's what we learned as a fifth point, as a key message. Now let's learn the next points as specific conditions. The common condition we see in our day-to-day practice in neonatology is RDS, TTN, pneumonia. You need to identify, you need to differentiate these three things in lung ultrasound. RDS means you will see subpleural consolidation, pleural line abnormal, and white lung. So you can see this white lung. You can't identify nice pleural line, and these white dots below the pleural line is called as subpleural consolidation. These are nothing but atelectasis. This is nothing but the lung atelectasis. So friends, this is a classic feature of grade 3, grade 4 RDS. So can I diagnose RDS? Perfect. Baby comes in me, and if I see such picture, I don't wait for X-ray nowadays. I call this baby for RDS and think about the surfactant therapy. You can see this baby before surfactant and after surfactant. This is the post-surfactant A lines. This is a B line pattern. This is a post-surfactant A line pattern. That's the advantage of having these ones. A lot of people have done the lung scoring. Lung scoring means scanning this 6 region. Anterior 2 on the right side, 2 on the left side, lateral 2 sides. If you see the A line pattern, it's 0 score. If you see the B line pattern, is 1 score. If you see the white lung pattern, it is 2 score. And if you see the consolidation pattern, it is 3 score. On these 6 regions, maximum score will be 18. And that's a research done by our team also, various research in the world. And we also have done in the Indian research, and that's published last month in the Frontiers in Pediatrics International Journal, that if my lung score is more than 7, 6 regions I have scanned, right upper, lower, left upper, lower, and I have seen the laterals and the scores are more than 7, I will give immediately the first dose of surfactant. Nowadays, I don't wait for 12 hours for second dose. I scan the second ultrasound in 6 hours. After 6 hours, my scores are more than 10. I use second dose. And this is done by one of our DM candidate, Dr. Pari, and she presented this one into the IIP Neocon also as a gold medal paper. And this is very useful, that diagnosing RDS on lung ultrasound, deciding the need of surfactant on lung ultrasound, decision of second dose of surfactant on the need of lung ultrasound, it's a very useful thing. Very, very useful thing. Second point, TTN. TTN means fluid. So TTN means edema without consolidation on the lung ultrasound. You are talking about lung edema without consolidation. That is the TTN. And you see a lot of things, what I told you, double lung point. A pattern, B pattern. That's a double lung point. Lots of AIS pattern, but the lung sliding is there, no pneumonia is there. That's nothing but the TTN. Once you see TTN, you don't require ventilation. Baby is on CPAP or flow, you can say that we can wean the baby. Just today only, I got a baby who is a 32-weeker. Everybody said that baby is distress, lungs basically bad. And X-ray not done, immediately done the lung ultrasound. And we said that this is normal. I could see the in between A lines also. This baby will not require surfactant. That's the advantage of not doing X-ray, not only doing ultrasound. That's what I'll come to the next point. So TTN means no consolidation. RDS means consolidation and pleural line abnormality. TTN means lung edema, could be double lung point, or basically the no consolidation. RDS means consolidation, pleural line abnormality with the lung edema. What about pneumonia? That's the commonest diagnosis in India, more than RDS. Remember this statement. You should diagnose more pneumonia than RDS. What is that? By posterior scans. Posterior scans, you will see the hepatization of lung. In between that, you will see the Schrader sign. Schrader sign means dot, 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 dot on the boundaries of the pneumonia. Small pneumonia, big pneumonia, you can able. I'll show you a lot of pneumonias. So this is hepatization. This is Schrader sign. And these white dots are air bronchogram. Air is moving in between. That's called as air bronchogram. Lots of these ones. Lots of these ones you can see. I'll show plenty of pictures now. Plenty of videos now. See, this is nothing but a big pneumonia. This is pneumonia. This is Schrader sign. These white dots are consolidation. These white dots are consolidation. This is classic pneumonia, which is differentiating from this lung to this one. So hepatization, Schrader sign with air bronchogram. Air is moving. This air moving is called as a dynamic air bronchogram. And if the air is not moving, it's called static air bronchogram. And that static air bronchogram is a feature of atelectasis. Same features. And if this air is not moving, it's called as atelectasis. So you should be able to know pneumonia versus atelectasis. I hope this is simple. Pneumonia means hepatization, air bronchogram, which is the dynamic Schrader sign. Consolidation, that's a good point. Atelectasis, no air bronchogram moving, that is a static air bronchogram. That is what we call it. Another feature you can see now, you can see this one nicely. You can able to visualize, this is consolidation, this is Schrader sign, and you can see the air bronchogram, air is moving. That's a simple example. Can you see this one? This is a posterior pneumonia. In this one, X-ray is showing pneumonia. My anterior scans are normal. Anterior and lateral scans are normal. I did a posterior scan. And the posterior scan, that's hepatization. That's what you can see the Schrader sign, and you can able to see air bronchogram. So that's very important. This is the sympneumonic effusion. Pneumonia, air bronchogram. This is the fluid sympneumonic effusion. This is nothing but the empyema thorax necessitans. From these rib, the pus is going to the subcutaneous tissue also. That's the classic things. You can see, friends, something different, which is useful in PICU. Lots of pneumonias, effusions you see. This is the baby with lung abscess. Hence, one more paper written by our team, that lung ultrasound for pneumonias. And this paper published in this last month in the Newborn International Journal. Pneumonia with hepatization, Schrader sign, mild version of severity. Pneumonia with sympneumonic effusion, moderate. Pneumonia with effusion with the particles, moderate. Empyema, severe. Lung abscess, severe. So you can diagnose all these things as developing countries. It's very useful. A few members have joined from other parts of the world. They might not see the empyema and lung abscess, but in India, we do see, or Asia and Africa, we do see these things as the lung ultrasound, those things. So friends, you see this whiteout lung with the sympneumonic, with some subpleural consolidation. That's RDS. You see the double lung point with the lung sliding moving. That's a TTM. When you see such hepatization lung, that's nothing but pneumonia. This is the three conditions you should know by heart on the lung ultrasound. That's a part and parcel of our skill. And this is the scoring system, what we have done, what we are designing our unit. That's published in the Newborn Journal. Go through that. It is very useful for all of you. This article is freely available. The next two conditions are diagnostic as well as therapeutic. You should work on that. I told you RDS, TT, and pneumonia, but the pneumothorax and pleural effusion also you should know. The pneumothorax, I already mentioned that the lung sliding is absent and the A line is there, which is pathological. And because of the lung sliding absent, you see both the side lung point. That means one side lung is moving, another side lung is not moving. I'll show you that lung points. So what happens now? Just watch this video. These lungs are moving. These two lungs are moving. This lung is not moving. So this is the lung sliding present. This is the absent lung sliding. This is lung point. This is lung point. This is the A lines. These are the B lines. So absent lung sliding, pathological A line, and basically you put M mode, Once you put a M mode, friends, you will see this barcode sign. Now, normally you see this sand beach and you see now this barcode sign. Because of the air, you see white out. This is called as a barcode sign. So pathological aligns, lung sliding, absent, and barcode sign. These are the classic features of pneumothorax. Everybody should diagnose. In 1 minute, in 10 seconds, you will diagnose pneumothorax. You don't require X-ray. Sensitivity, specificity, 99%. So this is the chart, what we designed in this paper, that if your lung sliding is absent and you have lung point and you have barcode sign, that's the diagnosis of pneumothorax. Lung sliding is absent, you have lung point and barcode sign is present, that's your pneumothorax. Remember, fluid is the simple thing to diagnose. That is, a pleural effusion means anechoic, means black color. That is what is the simple thing to diagnose about fluid, which is effusion. Simple thing is a lateral, which is called as axillary ultrasound. You will see about the liver, diaphragm, lungs. And the fluid will look like as anechoic, which is a black color, which is effusion, which will be visualized here. And the common thing for effusion is pneumonic effusion, pneumonia-related effusion in India. That's what we just saw. So always find out that these are the particles inside the pneumonia. These are the empyema. These are the septations in the empyema, which are the pediatric patients, not a neonatal patient, but you also see those ones which are useful in your day-to-day practice. Diagnostic, therapeutic. Pneumothorax, diagnostic, therapeutic. You have to put the drain and then confirm. So crashing neonate protocol, lung ultrasound is mandatory. I'll come to that point. So friends, I will not go to these other conditions, but you should concentrate on these 5 conditions, which are very important as RDS, TTN, pneumonia, and pneumothorax and effusion, because other conditions will have required more times, or basically they are different. Now, I told you about diagnostics therapeutic, but I told you the research. I already told you that first diagnosis of RDS by ultrasound, first dose of surfactant by ultrasound, second dose of surfactant by ultrasound. We also done the systemic review and we said that the baby is less than 28 weeks. If I do the scan on day 7, and if my scores on day 7, if my scores on day 7 are more than 8, baby will land up with the BPD. One of our DM candidates is doing now scores on day 14 and day 28. And we are thinking, can I predict the baby's weaning respiratory support at 28 days? Which babies will require respiratory support on the basis of lung scan? That's one of the DM candidates doing that present moment thesis. Another DM candidate has compared reduction of X-ray in our unit. In the last 5 years, we have reduced the X-ray by 50%. We don't do routine X-ray now for any respiratory distress. We do routinely lung ultrasound. And all DM candidates, they perform lung ultrasound. Your WhatsApp group, you get X-ray. In my WhatsApp group, I get a lung ultrasound picture. They write down lung score, they write down all the findings of lungs, and they say that this baby, we are managing conservative, we are doing insure, we are doing surfactant, we are doing mist, what are that? That's the role of lung ultrasound. And that's one of the paper which is in pipeline about the reduction of X-ray after lung ultrasound. One more paper is about extubation on the basis of lung ultrasound. Weaning the respiratory support on the basis of lung ultrasound, recruitment of the lung on the basis of lung ultrasound. So many advantages of lung ultrasound. You guys are currently only convinced with RDS. We are going one step ahead. Can I recruit the lung? Can I wean the baby? Can I extubate the baby? So clinician is doing extubation on his own parameters, and our DM candidate is doing lung ultrasound. What we saw that when lung ultrasound score is less than 4, that baby is ready for extubation. That's a correlation. So people, please, it is not, we need to go one step ahead. That research is paramount important. Those who are attending this session, they knows my views. We want a lot of research. We want to publish what is our own data. That will be the future for all of us. So friends, last 5 years, we have taken this focus at a different level in the world. And we started publishing all. So far, so we almost published 31 original articles in the focus and hemodynamics. And that's very useful for all of us. This is the international guidelines we published. And I represented Asia with all the important people from the world about the focus. And this is the one in the crashing unit protocol. Lung ultrasound has very important value. Check consolidation, check effusion, check pneumothorax. That's the role, other than cardiac and abdomen cardiac focus and the cranial focus. So lung ultrasound is very, very useful in crashing unit. Baby deteriorates, lung ultrasound is mandatory. We have written a lot of articles. Basically, this is Indian Pediatrics, this is Neonatology, this is, I told you, the International Journal Newborn. That's where we written. This is the last year for India. We have written focus in India, the way forward. This is the one which we thought basically last 4 years. Why can't we learn? Why can't we share? Why can't we encourage the focus in various parts of the world? And same thing in India. And that's what we have designed the models for medical schools and spreading in these ones. We have written a lot of basically the books. Few of you know that these books are available. These are the important books of the echo or lung. And you can see here, Champion Kunal is here, your own NNF secretary, Gujarat NNF secretary, who contributed this book of echo, then the lung book and the brain book and various other books, what we have written. So friends, whatever you know, write down. Whatever you know, publish. That is the future for all of us, which is important. I think you all know the hemodynamics book by Professor Richard Pauline, and this is where we have written the article on the hemodynamics. This is the book by Eugen Singh on the focus, written the article on the focus. Cohorty manual, again written the articles on this new cohorty, 3 chapters by our team. IAP textbook, all the focus articles by our team. So write down those things which are there. Vishal just mentioned, we have turned the world. We have changed the thought process in the world. People say that focus means you have to learn offline. You have to visit the center. You have to learn. We have changed that process whole. A lot of people do ask me how you are doing online classes, how the people are learning online. And friends, not 1%, 10%. We have trained 390 people from the world so far. That's a huge number. And these are the people from not only India, US, UK, Canada, Australia, from Middle East, from Asia, Africa. A lot of them have joined today now. A lot of them are listening now. So we have changed the world by training. Indian people are good in training. Utilize this. We are good as a Gurukul concept. We have a good concept of that one. These are the members from various batches. Few of you already there. You all know. This is the 6th batch, which is currently ongoing. And we are enjoying that with a lot of members here. Friends, focus is the future in neonatology. So neonatal focus, yes, examination and history is remain. You should be good clinician. You have to learn good clinical practice. If you learn good clinical practice, then you can correlate. This is what we are talking. What is important is this focus is the future in neonatology, along with your history clinical examination. So friend, this is the focus way forward. One of the champion people, along with Kunal, this is Dr. Rat and Dr. Nagpal. These are the champion members of our focus. They have written this article. And that's what we said, that portable ultrasound is the future stethoscope. You all have to learn. No choice. A lot of people say that, oh, this is not for me. Today you will say no for me. After 2 years, after 5 years, you will say, oh, I have to learn. No choice on that. This is what we are talking about, this one. So friends, lung ultrasound is very easy, point of care, radiation free, quick, repeatable. And naturally, we need to learn day by day. We need to put history and examination. We need to decide our decisions on the basis of these ones, perform the serial scan, and utilize the research. My humble request to all of you is a research. Whatever you want, I'm ready to train all of you. We have taken so far. Can you imagine 500 sessions? In last 4 years, we have taken 500 sessions. It's a huge number of sessions. Monday, Tuesday, Wednesday, Thursday, 9 to 11 p.m. That means, can you imagine 500 sessions multiplied by 2 hours? 1,000 hours of training we have done so far. And by that 1,000 hours of training, 400 members of focus, Neo Focus, and 150 members of Neo Pulse. Such 550 people we have trained online. No need to talk about 155 people we have trained offline. That is my fellowship, my fellow students or DM students, which are there since 2007. So we need to create training module. We need to train, and all these things. People say that, does it impact? A lot of Western people say, does it impact? We have written the paper on that online training is useful. Just now this Dr. Ayodeji, IODG has written. IODG has written that I'm from Nigeria, and this is he's enjoying the training. And Dr. Bhushan, there, our senior jewels of KM, just now written that Kunal is his student. Kunal is his student, and that's what is training who is going on. So friends, whether you are pediatrician or neonatologist, it doesn't matter. Who is a pediatrician? Who is neonatologist? We all are clinician. We all have to learn basics of lung ultrasound. That means in our day-to-day practice, this is a mandatory along with X-ray. X-ray has radiation. We want to reduce that X-ray radiation. And the X-ray radiation will be reduced by this lung ultrasound. You will say PCP, NDT, and that all. You have to put your evidence in front of that civil surgeon. Who is civil surgeon? Is a doctor. If you, all these 30 articles are freely available on the net. Just go to the PubMed, put Dr. Pradeep Suryavanshi, you will get all these articles. And you download this article, show to civil surgeon, then they understand that pediatricians are doing ultrasound. Who is a radiologist? In my time, pediatric was a topper branch. Every gold medalist used to take pediatrics. And radiologist was 5 or 6 branch. So if the radiologist can do ultrasound, why can't I do ultrasound? It is a point of care. It is a functional. I'm not diagnosing structural part. I'm diagnosing functional part. So friends, PCP indeed is also not bad. We have to prove that this is very important. Serial scans are useful in our day-to-day practice. That is what we are saying. So friends, you work for success. I know you want to work as a clinician. You have to work. You have to earn the money. You have to build your hospital. That is your mastery. That is what is a need as a clinician. But you select one area of your life for your satisfaction. And that one area, you decide what is that area. That is, you will become legend of that field. So those who are listening today, please think about research, think about publications, think about books. Whatever you know, write down. That will be useful for future generations. What we have not done in 1,000 years before, so we have not written the things down. Hence, we were behind. But we are very knowledgeable people. In the world, we are going to govern future things if we share the knowledge. And that's what our theme, sharing is caring. That's what we are reaching to unreached people. So friends, this is my request to all young people. I'm also young. We requesting young researcher to think about research. With this, I think I'll stop here because that's the thought process from my side. And yes, Rajiv, in pneumothorax, lung sliding is absent. That's called a lung point. In TTM, lung sliding is present. That's why it is called as TTM. So this is what from my side. Any questions, friends? Any questions? I have already replied a few questions on chat box. And any questions, I'm ready to. We have 10 more minutes or 5 minutes, whatever the Dr. Shwetal ma'am and Kunal sir, they will, or Vishal sir, any points. I could see the lot of members from our team, Jayanta, Rajendra, Jalil, basically almost I know the 90% of people, those who are joined here. I know they are still listening daily. I don't know why they listen. This could be the 10th time Jayanta might be listening. This could be the 10th time Rajendra could be listening, but I enjoy that, spreading these points. So those members, please think about this, utilizing lung ultrasound. And I would say that Kunal is there. Kunal can think furthermore, writing books. That would be good for all of you. Okay, back to Vishal, Shwetal ma'am, and Kunal.
Thank you so much. It is really honor, always when we listen you, it is always the time, we forget about time and we just listen you and we apply in our routine analysis rounds. And it is always pleasure to listen you, sir. And very informative lecture, for the lung ultrasound, as you say, is the simplest ultrasound in the earth. And we should apply our day-to-day practice to reduce the radiation and everything. Does anyone has any question? Let's see on the chat box.
Vishal, there is one question from Dr. Rajiv.
Yeah, so
Yeah. So I saw the question, Rajiv. Yeah. I saw the question, Rajiv. The scores preferably less than 5. You don't require surfactant therapy. Suppose you have done the lung ultrasound at 1 hour, score is less than 5, definitely you will not require that one. But the scores borderline, suppose 7, 6, 7, 8, then you might require lung ultrasound. Again, lung ultrasound after 2 hours, better to do that. But it is very clear that score more than 7 within 2 hours you require. That's what research I published. That is what you are going to think as more than 7, 8 or anything, you will require that surfactant therapy. That's what is important.
Thank you.
Sir, I have one question from my side.
Yes,
Like
Vishal.
we used to do the lung ultrasound since I think few months over in Arpan also. And as I, just I read lots of books, including your. But if we see the spare area, like if we see the A line in any region of the lung, should we say that this baby does not have RDS?
Okay, very good point. Yeah. See, very simple thing that A means physiological air. That's the first thing we have to understand. A with the lung sliding, physiological air. RDS means what? Most of the regions of area involved, and that rules out your RDS diagnosis. You have to find out other diagnosis, because you will be saying that this could be another fluid, this could be another part of what are the fluids you are diagnosing. So wherever any areas you are seeing a lot of A lines, you are going away from the diagnosis of
RDS.
RDS.
So
You are
yeah.
going
So
away from
that's
the RDS. So
so in that case,
always,
suppose sorry, sir, sorry.
no,
Just
no,
continue, sir.
please, Vishal, go ahead, go ahead.
So that means if suppose like what we are doing, like if specific like if I talk about the less than 32 weeker, 20 to 32 weeker, and if we thought that the baby has a spare area, like we can see that that anterior region is A line and posterior region we can see the confluent B line. Should we, if we could not count the score, for example, because it is difficult to, to handle the 600 gram or something, turn the posterior side. And but if we see that after one certain baby has a line, but still have a somehow FI2 requirement like more than 25-30%, should we wait or should we give the surfactant? Because
Very
the
good question,
scoring,
Vishal. Yeah,
yeah,
yeah. I would ask all of you here one more point. In India, spared area with distress means A lines with still distress means you are missing pneumonia somewhere. Why the baby has a distress or oxygen requirement? Suppose it's 30 weeker, 32 weeker. Baby is not having bad RDS, but still having distress, still requiring oxygen 30%. You have to screen posterior part of lung. The biggest culprit is that we don't screen the posterior part and we miss the pneumonia. That's what I think I have shown one of the pictures of posterior pneumonia from Dr. Malvika or Dr. Jayanta. They have shared all these nice videos. One of the research is going on in my unit, Vishal, 6 region scanning versus 12 region scanning. What happens in 6 region scanning? You are not scanning posterior part, and you see the A lines or you see the fluid part, B lines, simple B lines, and you say this baby is okay. But if you scan the posterior part, you will find some sort of small or big pneumonia. Your diagnosis changes. I do give surfactant for pneumonia also. The research done by
okay,
Kunal only. If you see the Kunal's thesis is surfactant therapy for congenital pneumonia. And that is published, that citation is going on all over the world for RDS guidelines. If you see the RDS guidelines, reference number 37, in that guidelines is a Kunal's article that surfactant therapy for congenital pneumonia. It is out of the contest, but if you diagnose pneumonia, baby is more than 35% oxygen, I can give the surfactant also. But I do agree, if you see A lines, most of the times you are ruling out RDS, but you are not
away from the RDS. Yeah.
but you are not ruling out pneumonia.
Yes, sir.
Suppose I know you are working in the center where there is a lot of clean babies you get, but a lot of people, they work in the periphery of India where the clean babies might not be there and they might miss the pneumonia, which I don't want. Hence, don't follow 6 region scan. Follow the 12 region scan. What I'm trying to say, 12 region scan, please 1 second, not 1 second, 30 seconds. Ask the nursing staff to turn the baby one side. If you do from tomorrow for 1 month, all of you do 1 month turning the baby to one side, baby is more than 30% oxygen. you will find pneumonia in these babies. This is my challenge to all of you. We are underdiagnosing pneumonia. We are overdiagnosing RDS. Please remember this statement. We are overdiagnosing RDS. We are underdiagnosing pneumonia. In the medical school, especially government medical schools, babies more than 28 weeks, a lot of them are pneumonia rather than RDS. IVF babies, they are different. I work in the both setups. I work in corporate hospital. I work in the medical school also. In corporate hospital, I get a lot of RDS. In medical schools, I get pneumonia. This is what I'm trying to say you.
Yeah. So one more question from my side. If you give the surfactant, how
Vishal, unmute yourself. Vishal, unmute yourself.
this is all in between. So how long it will take, time to disappear of the B line? So it will take 12 hours or more than that?
Very good
Because
question. Yes.
as I remember, just few of people when I trained in the UK, they said that it will take more than 48 hours. So I don't know what's the thing,
No. I'll just tell you. If your scores are more than 10,
Okay.
if your scores are more than 10, it takes more than 24 hours. If your
Okay.
scores are between 7 to 10, within 6 to 12 hours, you get A lines.
Okay, that's
Severity.
So,
What is A line? A line means alveolization. A lines means opening
Yeah.
of lung. A line means alveoli opened up. If the scores are less, alveoli open up early. If the scores are high, alveoli will take more time. That is called as recruitization. That is called as the recruitment of lung. That is called as what we are talking about, the lung scans. You will not require second dose that time. That is what we are talking. Yes, Dr.
so
Sheetal.
yes. So can you say, sir, that if the scores are more, we should be ready with the second dose?
Yes, very good question. Whenever your scores are 10, 12, 14, you might end up with second dose. I don't wait for 12 hours now.
Yeah.
I do
So
my
that's what. At what
I do my
hour of
scan.
life?
I do my scan at 6 hours of life.
Okay. So after giving
I-
surfactant, again after 6 hours, you do a scan. And
Second
if the
scan,
scores
if
are more
it's
than
more
7,
than
you will go for second.
no, more than 10, more than 10.
Acha, 10. Okay. Because 7 is the cutoff for giving surfactant.
70 is put up for giving first dose.
First dose. Okay.
Because after 6 hours, you might have still the fluid in the lung little bit.
Yes.
So
So
you require
that, sir, then in that case, your unit won't be having any more BPDs also, because there is no lingering of ventilation and
yeah. Because now you can see now few of my students have joined. We have stopped one study because a lot of babies in our unit are more than 26 weeker. We had a one study of assessment of BPD on the basis of lung ultrasound. But
yeah,
we have
you
stopped
say.
the study. We have stopped the study because we are not getting BPD now.
Okay.
Which are the patients you get BPD less than 28 weeker?
less than 26 weeker.
And then with the newer definitions, it has become difficult to label BPD. And then you say that I have to withdraw the study because you are not getting that type of patients. So
Yes.
this is what you should do. Always, we all know less is more. Less
Yeah.
ventilation, you are getting better.
Perfect.
Less early surfactant, you are getting better. So I think we know that.
Good. Very nice.
Any other questions from the participant?
Fantastic. Good evening, Jatin. I could see Jatin also, champion boy from Rajkot. Fantastic, wonderful. So I think most of the people we have discussed most of the points.
Yeah.
And
Pradeep,
it's
sir?
8 o'clock.
Yes.
If you
Yes. Yeah.
any more points they can ask.
No, sir. I would
no?
like to thank you for taking such a. I'm listening this second time. I would like to listen more and more till I get established in my unit, the ultrasound. So it's an excellent session. And the message of sir, ki, pursue your passion, find out your ikigai in your clinical field, and go ahead with that. And the research, yes, we lack in our own data. So that was really a great tips or a great suggestion what you have given. Whatever we are doing, we should write up. That's great. Thank you so much, sir. Very nice session. The words are less, sir. Nice is not very good session. Very excellent session.
Thank you
Good
so
night.
much, sir.
Good night. Good night.
Thank you so much. Thank you, ma'am.
Thank you so much, sir, for
Thank you. Thank you, Kunal.
Thank you, Vishal. Thank you, Shwetal ma'am.
Thank you. Thanks a lot.
Thank you.
Thank you, sir. Thank you.
All right. Thank you so much, everyone. Hoping to meet you again on this platform very soon for any other next sessions. With all the due permissions, can we conclude the session over here?
Yeah, sure. Ankita, you
Thank
can.
you.
Yeah.